the Public Interest MS program with Dr. Adrian Fu Berman, who is with us as well. And it's our pleasure today to bring this seminar by Puya Jafari, MD. You'll hear an introduction of him by by Margot, our moderator, in a bit. But let me tell you just a little bit about the program and how we're going to run this seminar today, and then we'll move to Margot, who will do a formal introduction of Dr. Jafari. So the Health in the Public Interest program is a one-year MS program that is in some ways like a public health program, but emphasizes social determinants of health and places a high value on advocacy and activism among the students that we train. We're not looking for people who will work within the status quo so much as who will work to improve the healthcare system and to improve it for all people. So the seminar today is going to be introduced by Margot momentarily. The way that we run this is we leave lots of time for questions. We usually keep people muted during the seminar if you're used to that, but Dr. Jafari is going to try to get some interaction going today with you also. We'll see how he wants to do that. Dr. Jafari is kind of a special guest today because he is an on-the-ground healthcare worker. We're usually dealing with people who are working in policy, research, etc. And I thought it would be good to bring in someone who has actual day-to-day experience working with underserved populations and can share with you all some of the things that he gets into and some of the things that he believes are important in considering this population. So at this point, I will turn it over to Margot, who will introduce Dr. Jafari, and then he will get started.
Great. Thank you, Dr. Myers. Hi, everyone. My name is Margot Johnson-Green, and I am a second-year student in the HAPI program. And today, I have the pleasure of formally introducing Dr. Puya Jafari. Dr. Jafari is an internist practicing in Washington, D.C. He received his medical degree from the George Washington University School of Medicine and Health Sciences, specializing in internal medicine with a concentration in underserved medicine and public health. He has several years' experience working at Samaritan Inn and Hunt Place Health Center in Washington, D.C., and as an AmeriCorps member, and currently is an internist with Unity Healthcare. And if that wasn't impressive enough, recently, Dr. Jafari has started to follow professional sumo, and in his spare time, he enjoys paddling on the Potomac. And with that, I will pass it over to you, Dr. Jafari.
All right. Thank you so much for the introduction. All right, let me just share my screen. Okay, can I get a confirmation that this presentation, do you guys see the presentation?
No, not yet.
Not yet. Let me, sometimes you have to reshare it. Okay.
There we go.
Awesome. Okay. Hi, everyone. My name is Puya. I have these slides. These are slides that I created for actually residents at GW who I work with, and also med students at GW in Georgetown, just to give them an idea of kind of common topics that we address in healthcare for the homeless. I should say that Unity Healthcare, if you're not familiar, is the largest FQHC, federally qualified health center in DC. We have tens of thousands of patients. We have like 15, 18 or so sites, clinic sites. Clinic sites can be as large as, multiple floors with some specialties, laboratories, pharmacies, or sites as small as what I do, basically, which might be just me and a medical assistant in a one-room clinic, basically. So the whole idea was to, increase access by reducing barriers to seeing us. So basically opening up clinics closer to where our patients are. So that's Unity Healthcare. There are other FQHCs in DC. We're not the only one, but we just happen to be one of the older ones and and the largest one. And the other thing I just want to put out there, a lot of times friends and family ask me, like, what do I do? They're like, oh, your patients are homeless. What exactly do you do? So ultimately what I do is practice medicine. I'm an internist, so I do primary care and internal medicine. And the thing that makes what I do unique is the clinic settings that I work at. So I do work at a regular healthcare, like a community healthcare setting, with nurses, MAs, laboratories, pharmacies, etc. But a lot of my sessions throughout the week are could be at a shelter. So a lot of times we'll have our own small clinic based at a shelter, or maybe based at something called a day center, also known as a drop-in center, which is ideally like a one-stop shop place where you can get laundry, showers, and case management by other agencies. And the other unique thing I do, which you don't see a lot of these days, is walking outreach. So twice, 2 afternoons, or one morning and an afternoon a week, I go out with a case manager from a local organization, and we'll just do rounds. We call them street rounds, walking outreach, and we'll walk around the neighborhood, looking for clients, following up on clients, trying to, again, address any barriers that they may have to seek healthcare. Most of those visits, obviously, medical issues are kind of a small part of their healthcare, as we all know, of all the social determinants of health. Medical care is just a small fraction of what's contributing to their healthcare. But that's a very unique thing that I do. And so that's basically what I do. Yeah. So I think we have like about 40 minutes, maybe a little less, allotted for these slides. I would love to just kind of go through them fairly quickly. I do have some natural breaks in these slides, and I have the chat window actually open on my phone. So if questions arise, you can type it in the chat, and I'll address it during these breaks that I put in these slides. Otherwise, we can also talk after the slides are over, when the discussion starts. Okay. I'm gonna breeze through some of these. These slides are for like new medical residents and med students new to DC. If you want to understand your patient population, you should try to understand the city itself. So DC is obviously divided into wards, 8 of them. DC, like many cities, is highly segregated. And I think we need to appreciate like the physical boundaries of segregation in cities as well. So here in DC, that black area there is Rock Creek Park. And it's very stark. I find this just quite a stark slide, where you see to the left of the park where Georgetown is located, mostly white, right? And then to the right of the park, mostly non-white, essentially. And then down in the bottom right corner, there's a river there, the Anacostia. Oftentimes, patients might say, I live, on the other side of the river, east of the Anacostia. And so that is, at this moment in history, it's almost entirely non-white African Americans there. Along with segregation, a lot of healthcare determinants are also reflected in how we divide cities. And the next few slides, just to appreciate, I'm not saying anything new here. Hopefully this isn't a surprise, but if you look at many different metrics, many of them overlap. So here we look at poor, quote unquote, poor health and poverty, right? So the darker areas again there are wards 7 and 8, by the way, which is divided from the rest of the city by the Anacostia River. Just moving forward, no surprises here again. We look at how it overlaps with education. We look at how it overlaps with history of incarceration. I find this very interesting. This is basically the proportion of emergency room visits by residents for which their discharge diagnosis from the ED was considered to be a primary health concern or primary care concern, not necessarily an urgent or an emergency concern. So we see high ED utilizations in these same neighborhoods, especially wards 7 and 8. And this is particularly important because the city has opened up multiple healthcare centers in 7 and 8. So they'll have to kind of monitor this to see, okay, if we open up a primary care clinic in Ward 8 or 7, are we going to see better utilization of primary care? Are we going to see less utilization of emergency rooms? I will tell you from, my experience, particularly my experience with my unhoused or homeless patients, a large majority of my patients utilize the emergency room as their urgent care. And it's a very complicated thing to address. And when I'm in clinic, I personally find it to be a win when I can treat something and have that person avoid going to the emergency room where they'll have to wait hours on end and just better utilize our healthcare services. So that's one of the rare wins in my work when I can do that. Well, obviously, I'm not an expert on some of these slides, but I just want people to appreciate how, how a divided city can present in different ways. So we have areas of food scarcity, right? So lack of access to healthy, nutritious foods. Again, predominantly in wards 7 and 8 here. And then this is a graph from the Washington Post showing how far it is to get to a grocery store. So again, in wards 7 and 8, you might have to travel upwards of a mile to get to a grocery store. Where I live in Adams Morgan, in Columbia Heights, there's a grocery store on my block. There's a Trader Joe's 4 blocks away. There's a Whole Foods 8 blocks away. There's a Harris Teeter 6 or 7 blocks away. So so I think from a social determinants of health perspective, we need to consider some of these structural issues that we need to deal with in order to address, healthier living. Okay, this is my first break. This is a picture of the Anacostia, beautiful, beautiful river. No questions yet. One thing I want to hopefully share with you guys is that when I talk about my patients, and I often say homeless patient, and really that's not correct. It's really someone who's experiencing homelessness, because we want to avoid creating labels. But my patients, my experience with unhoused patients or people experiencing homelessness is quite different than other people's experiences. To be unhoused, I think maybe in mainstream media and et cetera, you might have a picture of what it is to be homeless. So if I ask someone, hey, what is your idea? If you could pick a picture of someone who is homeless, what would that look like to you? And just think about that. Just what picture like pops into your head? I think for a lot of us, it would be mostly folks who are chronically homeless, right? People who have been homeless for a long time or multiple times. People who are unhoused, maybe living in an encampment. I just want to stress that that's like a very small portion of people experiencing homelessness, because just like any population of people, we have to appreciate the diversity of those people. So in my experience with my patients are predominantly individuals, not families, but individuals experiencing homelessness. They're also individuals who are generally what we say chronically homeless, which is an official definition, where you've been homeless for longer than a year or homeless multiple times throughout the year. And in my population of patients, chronic mental illness is extremely common. Now, I'm not saying every person who's experiencing homelessness is chronically mentally ill. It's just simply the population that I serve. Okay, so I just want to really put that out there, and I don't want you to leave this presentation thinking, you have just one picture of what it is to experience homelessness or a patient who is homeless. Okay, but I couldn't like be more clear about that, right? Were there any questions so far? I know I breezed through those kind of demographics about the city. Just want to get through those quickly. Oh, great. Awesome. How do I keep track of patients unhoused? Yes. Yes. Common health issues. Okay. So how do I keep track of patients for follow-up? A lot of my patients don't have phones. So the way first of all, we're a medical system. So we document everything like you're any other patient. To keep track of patients, sometimes we will know, like, for example, I often ask where they're sleeping at, where they're living at, so we might know where their shelter is. If I have labs done for someone, often, like today, my patients had labs done without phones, so I'll tell them to come back and see me in a week, and we'll review them together. Sometimes you can't track your patients, so on those times, I might be on walking outreach where I'll literally go out with a case manager and look for the patient. Maybe there's a outstanding something to follow up on, and so we'll literally just go and look for them. We'll use CRISP, which has access to the hospital records in DC to see where the patient is. A lot of times, case managers will ask me, "Hey, I can't find my client. Can you help me see if he's in a hospital or she's in a hospital?" So I'll look through the shared database of hospital records to help out. Unfortunately, sometimes we'll call the medical examiner too to see if someone had died. It's difficult to keep up appointments. Absolutely, absolutely. And we'll talk a little bit about competing demands briefly. These are one of the topics in homeless healthcare. Is you have to understand. I mean, I should say you as a provider, but me when I talk to other doctors, that people have competing demands. Their healthcare may not be prioritized over their meeting in an hour with their case manager to get the keys to their apartment or to submit the paperwork needed to apply for a housing voucher. So we have to kind of get out of this mindset that, their medical care is the number one priority. And oftentimes it's not. Not to mention transportation, not to mention being late to visits to specialists because transportation didn't show up or transportation couldn't find them or the bus was late, et cetera, et cetera. Health issues, I'll go into that with slides later. Next question, could you go a little more into the possible reasons that the emergency department is the first? Why? So possible reasons for the emergency department as a first source of care. Well, I mean, they're open all the time, well, number one. Number two, if you need imaging done and it's serious, you can get that imaging done immediately, right? Imagine being unhoused and you come in with knee pain and I want to see if you have arthritis. I have to give you a referral to get an x-ray, and then you have to take that referral to one of the radiology centers in the city to get an x-ray. And then I have to get those results about the x-ray. You have to come back and see me and we have to review those. So part of the reason I think emergency rooms are popular is because they get stuff done quickly. But there's a lot of other reasons that I probably don't understand too about why. But mostly it's just access, right? It's easy to go there, and emergency rooms cannot refuse care. Thank you, Dr. Jafari. You mentioned it's really rare for doctors like you to do street runs. Why? Oh, I'm so glad you asked me. So why is it rare for doctors to do street rounds? Well, first of all, it's hard. You have to have a good program. And to be honest, what I do, we could do it better. A really good street medicine program would probably have a nurse practitioner, a registered nurse, a case manager that can help sign up for insurance, all along with an MD or not an MD. You don't need an MD. You just need an independent practicing provider to supervise all that. You kind of need all that if you really want to do a really comprehensive street medicine program. what I do is I go out walk with one case manager who helps with non-medical stuff. So that's one thing. It's hard to set up. Two is, how are you going to bill for this? You can bill. I bill for it. But if a lot of your patients might not have insurance, and I don't have a case manager with me that can get them signed up as soon as I see them, you know? Number two, it's a lot of work. Like, I'm not that old, but I'm exhausted just walking around 2 to 3 hours when it's 90 degrees outside, right? Or it's sub-zero temperatures, right? It's freezing temperatures. So you're not going to see a lot of people. So your clinic, my clinic, for example, gets on me about, okay, hey doc, we pay you all this money. You got to increase the number of visits that you that you're seeing so that we can, be a profitable nonprofit. So that's very challenging for what I do. Of course, I don't want to be too like pessimistic or skeptical. Part of it is increasing access. So the more people you see, you can arguably say, yeah, it's better because you're improving access. But ultimately, there is a bottom line that needs to be addressed. So that's why it's difficult. I won't get into how can we scale this to other parts of the country. I don't think you can scale it. Every community needs to have its own unique program. You cannot think that one program in DC will work in another community. And again, you have to appreciate the diversity of your patients in doing that. What is the most common health condition you see? We'll talk about that. Awesome. Great questions. I'm going to breeze through this. I want to kind of address some of these questions. So what is homelessness? What does it mean? Here's a definition that your federal government provides for you. So the point of this is that it's been defined by the federal government because we need to keep track of this because a lot of money and grants and policies are tied into what it means to be homeless, okay? Again, my patients, a lot of them, some of them experience homelessness transiently. Quite a few of them have gained housing and still come back and see us at our clinic. So they're no longer homeless. But the majority of my patients are chronically homeless, which actually has its own definition. So they've been homeless multiple times in a year or more than a year. And almost always, and excuse me for painting a broad brush here, but almost always there's a mental health component that's not being addressed. Not so often a substance use component, but more of a very severe mental health component. Okay, every year in most cities and metropolitan areas, they need to do a point in time count where they count the number of people experiencing homelessness. I just want to put this out there. If you look at the graph, let's look at the pie chart. And this is my experience. So I'm an adult medicine provider. So most people experiencing homelessness in DC are adults, okay? And the important thing I want to point out here in DC has done a really good job of housing families who have experienced homelessness. See that yellow line right there? That's down to about 1,000 there. They opened up a lot of, I don't know, they've just, I don't know if it's easier, or they've definitely opened up a lot of housing for families, but DC has done a pretty good job of that. Our individuals experiencing homelessness hasn't really changed much at all, okay? And in fact, it's gone up a little bit. You might notice this, right? If you see more encampments. So, again, my patients are almost 95, 99% individuals experiencing homelessness. A lot of them are on their own or might have a partner, etc. And by the way, let me just put this in perspective. If, we have, say in DC, around 5,000 or so people experiencing homelessness now, about 4,500 now, I think, around there. The state of California estimate 170,000, So just to put things in perspective, about, how much of a quote unquote problem this is in the city. My personal area of interest is really individuals who are homeless, but older individuals, because they tend to have more chronic medical conditions. Again, a lot of those chronic medical conditions are no different than what any other individual would experience. Heart disease, diabetes, heart disease, diabetes, cardiovascular disease, things like that. And then under that gender, this is actually quite representative of my patients. Majority are men, but a good proportion are women as well. And again, this is my experience in my clinics. The vast majority of my patients are Black. Lately, I've seen more Spanish-speaking patients, but that's mostly because of the migrants who have been bused or flown, mostly bused from the southern states to DC. And this ethnicity down there has changed a little bit because of that. Um, I I like this slide a lot, and we talk about how do we fix homelessness, how do we address it, but a lot of times we don't really think of like, well, how can we prevent it, in the first place, right? I'm in primary care. We're talking about preventive medicine. Let's talk about trying to do things to prevent homelessness, right? So the top bar graph there talks about being systems involved, either in the adult justice system or the juvenile justice system, or being in foster care. That can also be considered like systems involved. And I can't tell you like how many of my patients, usually older Black men, who have a history of incarceration, and then they're released from prison or jail, and they go to a halfway house, and then after that there's like nowhere to go. They end up in the shelters. I had a guy who was in the Federal Bureau of Prisons. He got excellent health care. I mean, he was in his 60s. He had a lot of serious medical issues. And if you're in the Federal Bureau of Prisons, you get great health care. You really do. Once you're out of it, he came to me. He's like, here are all my meds. I don't have any insurance. Can you help me with medical care, And he was telling me, well, the only requirement they really had when he was released from federal prison was he needed to provide an address to say where he was. So he didn't actually have a place to stay. He stayed with his daughter, but he didn't even have health insurance at that point. So that's something to think about, that transition from being incarcerated to living in, civilian life. Unfortunately, domestic violence is way too common. I can't think of a patient of mine, generally a female patient of mine, who hasn't experienced some form of sexual assault or domestic violence in their history. But that goes for all my patients too, in terms of how much trauma they've experienced in their life. So that's and then other things here on these graphs just to look at later is child welfare history. So history of needing assistance as a child. And then, well, veterans as well there. But I didn't want to address those. I wouldn't really talk about being involved in the criminal justice system, as well as have a history of trauma, particularly sexual assault or domestic violence trauma for mostly female patients, but some men as well. And I don't put this up there to say, hey, these guys are making money, they should be able to, pull themselves by their bootstraps and take care of themselves. What I want you to appreciate again is this diversity of my patients experiencing homelessness. And a lot of my patients are unable to work, and they do get disability, So there is a little bit of income coming in. What I found fascinating when I did this job is I would ask some of my patients who are older and who had medical needs, why they weren't going to these great assisted living facilities where you're completely independent, but you have assigned a case manager. There might be a clinic on site. There might be meals provided, basically. And there's quite a few of them in DC that the city has opened up. And a lot of not a lot, some of my patients say, you know what, it sounds great, but they want to take all of my Social Security and disability income and just give me like $100 or $200 a month back. And they, a lot of people are not willing to give up their income. That was a very fascinating thing that I experienced and still do to this day. What is the usual age of homeless individuals? Can I just go back quickly here? It depends. Like my patients are generally on the older side. but I see it anywhere from, you know, the whole spectrum. I do. I see the whole spectrum. My concern is, at least in DC, is that we do have an aging population of individuals experiencing homelessness with chronic medical conditions, and we have to find ways to address that, at least from a medical perspective. But to answer your question, I would probably say, you know, 30s, 40s or so. The life expectancy is short, so we'll get to that, and that's going to affect what the average age is, or the usual age is, of someone experiencing homelessness. So here we go. Sorry, usually I'll ask the residents, what do you think the average age? You know, what age you think the average life expectancy is for someone experiencing homelessness? You'll get some different numbers. This one was from a federal study, but it's extremely young, obviously, extremely young. You know, in your 50s. That's incredible. And someone had asked, well, what are some medical conditions your patients face? What you see here is essentially what a lot of my patients face, particularly when it comes to chronic diseases. Now, there are other issues, like urgent issues, like bugs and rashes, exposure to heat and cold. So those do come up more frequently, obviously, but I just want you to appreciate that the chronic medical diseases that individuals who are unhoused are very similar to the issues that quote unquote regular patients face. It's just far more common, you know. So cardiovascular disease is I find it to be far more common. Untreated HIV is far more common. Lung issues or hepatitis are just more common. Okay. Great. This is a picture of our downtown library, Martin Luther King Library. That's 12:33. I think we're doing pretty good on time here. Sorry if I'm working quickly, but it's a lot to talk about. I actually don't know the answer to that. Same life expectancy for both men and women. That number there is for all individuals experiencing homelessness. So I don't know the answer to that. What do you guys think? I mean, let me ask you this. So why do you think so here we have cardiovascular disease like strokes and heart attacks. Why would that be more common among individuals experiencing homelessness? What do you guys think? You type it in the chat. It's not a trick question, really. Yeah, we definitely talk about lack of access to care, but compounding stress. Yes, that's one thing I think about a lot is stress and trauma. You know, there's a lot of research coming out about how trauma in early in your life can actually affect chronic diseases as you age. Poor access to healthy food, absolutely. Chronic stress, less ability to manage, absolutely. Less ability to manage. The vast majority of my patients with AIDS or HIV that's not treated, the vast majority of them are living in shelters or in a tent, so they're unhoused. They don't have reliable access or safe storage of their medicines. Oftentimes, more often than not, especially in my young male patients, they'll most often have an untreated chronic mental illness. Maybe it's just major depression that's not effectively treated without, you know, they're not going to get therapy, they're not going to get medical management, or they might have schizophrenia and might not have the medical insight or the health literacy there to understand why, we're urging them to take this pill every day. Yeah, no personal relationships. Environmental agents, great. Yeah, there are things that exposure to extremes in temperature. We know that it affects our bodies, right? In the acute sense, right? In hypothermia and hyperthermia. But what does it mean to be living in a environment like that over a long period of time when you're chronically homeless? And I do believe that environmental agents, particularly, hyperthermia, hypothermia, or just being exposed to the elements for long periods of time, do put you at risk for developing cardiomyopathies. Right, good, great questions. Another thing, just a kind of a practical thing, why are cardiovascular accidents more common? Quite a few of my patients have diabetes that require insulin, right? So one of the most challenging things is figuring out a way for my patients to not just get access. It's unfortunately in DC, we got DC Medicaid. It's great. I can get you insulin, but it's really the storage of the insulin that's difficult. So thank God, like DC Medicaid now covers the insulin pens. And a lot of my patients and providers don't know that those pens need to be refrigerated if they're unopened. But once they're opened, they can actually be kept with you, generally in room temperature, for upwards of 28 days. So at Unity, at one of my clinics, what we'll do is we'll keep your insulin in a refrigerator that's unused, and we'll hand you a pen. And that pen may last you for a few weeks, maybe the month, but you can just keep coming back for that pen. So that's something that I actually learned a few years ago, because I was always taught all insulin needs to be refrigerated all the time. So that's a huge issue among our patients with diabetes. Lack of adequate mental health wraparound service. Yeah, oh my goodness. We have so many resources for mental health, but you know what? It doesn't matter how many programs you create and set up. It's tough to get qualified individuals to work there, and it's really difficult when your patients don't want to engage in care. That doesn't mean you should just kick them off your roles, but you have to kind of work around that. This is basically what I do every single day. And, we talk about patient-centered approach. So what does that mean in my experience? Again, competing demands. I don't get upset anymore if someone doesn't take their medicines. Because I understand that that's not their priority. I try to understand the reasons for not taking their medicines, and then go from there. Meeting patients where they are. That's what I do every day. So I'm at sites that are at shelters or at these drop-in centers, or I'll be at walking outreach. It's funny. Some of my patients get better medical care than people who go to like Georgetown or GW. Like they have a doctor that goes directly to them and provides. I say I provide concierge medical care to homeless patients. And sometimes, sometimes breaking down those barriers is not enough, right? So I am addressing the access, but there's still so many other things that aren't being addressed, that are creating barriers to better health. These are some things that I tell my residents to ask their patients is we need to stop ending our visits with what questions do you have for me? That's old school. For my patients, and in fact other patients too, a better question is what barriers are you going to have? My patient I might prescribe insulin and I'll forget to ask, or they won't tell me, hey doc, I actually don't have a refrigerator. I'm staying on a shelter and the shelter has rules that we can't store anything in the refrigerator, or hey doc, my meds get stolen all the time at the shelter. Yeah, which happens a lot. Some of these shelters are just awful. So I tell my residents and anyone I'm precepting is just ask your patients, what do you think is going to be the hardest thing about doing this treatment? I added this performance-based evaluations. Again, this is kind of for people who are going into medicine and want to do what I do. Is that we have to rethink how am I being judged on how well I'm doing my job, right? So, you know, my bonuses are based on how many people I see, right? So someone asked me earlier, you know, about what was it about why is it hard? Why don't doctors do street rounds? Well, my bonus at the end of the year is based on VPH, visits per hour, and my goal that the organization has given all of us is 2.8 visits per hour. Because I like to do what I do, I'm basically not going to get that bonus. Because there's no way for me to see that many people at my clinics or at street outreach, because I can't do what I do in 15 minutes, you know, not when my patient's psychotic and lives at a shelter, you know? So that's that. My bonuses are based on actual metrics on healthcare, right? So A1C or blood pressure control. It doesn't matter how much counseling I do to a patient, you know, about what it means, what the A1C means, or what it means to treat diabetes so you don't lose an eye, you know, you don't go blind or lose a limb. But if your patient has low health literacy or has a chronic chronic mental illness that prevents them from having that insight into their disease, you know, you're not going to get that buy-in for them. We still do it. I still work on folks. I still address these issues, and I try to do as much education as possible and meet them where they're at. Maybe use different language, but yeah, some providers are in my field are kind of frustrated with some of these things, you know. So we have to be a little bit more creative in how we base performance for I think all providers in a federally qualified health center. I'm gonna skip this DC Medicaid. It's probably for another time. But thank goodness, and one of the reasons I like what I do, at least in DC, is thank goodness we have a fairly robust Medicaid program that is currently run by 3 managed care organizations. And it really helps, really, for me and the patient to be able to have this this service. Honestly, I wish we had just a nationalized healthcare system, because in my experience as a provider, the insulin that I prescribe is and will be different for each of these organizations. So I have to know, okay, this person has this insurance that only covers this type of long-acting insulin, because if I send the wrong one to the pharmacy, they're going to show up and they're going to be confused, and the pharmacist is going to say, it's not you, I can't give it to you, you have to talk to your doctor. And a lot of my patients have such a hard time just seeing me once. Now they got to come back to me. We got to figure all this out and just kind of start from scratch again. So there are some downsides to this, but I'm grateful we do have a very robust DC Medicaid program. This is great. I really want to, if you walk away with a couple things, I want you to think about kind of the diversity of patients experiencing homelessness, some of the medical issues. But medical respite is something that I think we need a lot more of. It's essentially, think of it like a rehab place where you're too sick to be out on the street, but you're too healthy to stay in the hospital, right? So say you go to Georgetown, you fractured a hip or you broke your leg, you got the surgery, you did the PT, whatnot. Okay, now you're ready for discharge, but you need a little bit of wound care, maybe a little bit of PT, maybe need some help with transportation to your physical therapy. We really need more of these programs where you could be discharged to a medical respite program and basically kind of finish that treatment. In the end, these medical respite programs do not necessarily just get you housing. That's not the point of them. It's basically a humane way to continue some of that treatment where you might be way too healthy to stay in the hospital, so they can't keep you there. And you're clearly a little bit too sick to just be out on the street or in a tent or even in a shelter, you know? So in DC, the most popular one, unfortunately, right now it's only for men. There is one for women. There's a few in DC. It's very difficult. The beds are there aren't a lot of beds for women. And actually, Unity is working right now on opening one up for women. But Christ House is probably the oldest one in the city, if not the oldest one. And it's a great place. Say you need a little bit of wound care, maybe you got uncontrolled diabetes or blood pressure, or you had some surgical procedure and you need a place to kind of get back on your feet. So medical respite is a huge topic in healthcare for the homeless. I just listed a few of them there here. Joseph's House, for example, I'm working in walking outreach with a client, who's really struggling with alcohol use, and he's not taking his meds. And we really think if he just had like some structure, some place he can call like his own room, we really think that'll help him take his meds regularly. So we're trying to get him, enrolled into Joseph's House so that he can take his medications. It used to be a hospice program for men and women with AIDS, but now they're really just trying to help anyone with AIDS who need that kind of stabilizing force in their lives. It is 12:47. I did work briefly at our pandemic hotels in DC. I wish we had more time to talk about it, but I want to really give you guys an opportunity to kind of ask questions now, or maybe discuss something that came up during my slides. I do have one question I can answer. What role or responsibility does society play in the stigma suffered by homeless persons? How do we break that cycle? We can break that cycle. So let me just be concrete here. So in my clinic, the way I break that cycle is if I see someone being treated without dignity, right? Without respect, and almost always it happens at these shelters, either through the security staff or the frontline staff, registration staff. I'm not here to judge. I know we all come from different places and we process emotions differently. But what we need to understand is that our patients have experienced significant trauma, and their internal response to any type of conflict or stimuli is completely different than how maybe one of us respond to it, right? So we cannot throw gas on a fire, right? So in my clinic, when I see something, like maybe with the MA, afterwards, I'll just kind of I'll set them aside, be like, hey, what's going on? I notice you kind of got into it with so and so. What was going on? What kind of triggered that? And just kind of work through that, and then have them work on approaching that conflict differently in a way that's healthy, that respects that person, and that tries best to empathize or sympathize with some of the trauma that they've experienced, and to understand that our patients react to stimuli much differently than you and I will. So that's a concrete thing that we can all do is if you see someone being disrespected like that, and if you're comfortable, approaching that, hopefully it's a colleague where you have a good relationship with, take some time to kind of talk about it and understand why that person reacted the way they did, and why they reacted the way they did. I don't know. That's just one small thing that I wish I could say I don't do often, but it needs to be done. Great. That's great question. I mean, what do you think? What do you guys think? What stigma is huge, and I think one thing is when I ask you how you would picture a homeless person, and think about what picture pops in your head, and then realize that's just a small segment of people experiencing homelessness. There are families, there are people who might just be staying with a friend, who might lose a job. It might be a temporary thing. And that's I think the goal for a lot of case managers I talk to about is, we might not be able to cure chronic homelessness, but we need to find a way to make homelessness as brief as possible.
Dr. Jafari, if you're open to taking other questions, I see that Katiana has her hand up.
Oh, thank you. Yes. Hi.
Hi, thank you so much. And I really appreciate your insight on why we're not seeing as many street medics like you are doing more. I've never seen that actually. So hopefully communities will be able to organize something like that one day, although it sounds like there are a lot of barriers. My other question is, in speaking with folks that like I live in Austin, and you see these downtown alliance people come and they clean up and they try to be friendly with the folks down there experiencing homelessness, and they do their best. And one of the fellows there told me, you know, the people that we're working with right now are not going to shelters because they're not allowed to do drugs there. So this is obviously an extremely generalized question, but wouldn't it be beneficial if folks, if they are doing drugs, would they be able to take them into shelters? Would that be beneficial, or would that cause more harm in your opinion?
Oh, wow. So there, so just to step back a bit, yes, there are different shelters with different barriers. Like some shelters would be a low barrier shelter, for example, that might allow you to, bring certain things in. When I practice medicine for my patients with opioid use disorder, I take a harm reduction approach. So a lot of my patients may not want to quit their heroin, but I'll tell them, here's some Narcan. We can talk about Suboxone, and if you're going to use, at least use around people who can call 911 if you do overdose. Listen, I don't know what the best solution for that particular scenario is going to be, but a lot of, I would say this, at least in DC, a lot of these low barrier shelters are not good places to be. And most of my patients tell me that, I mean, some of my patients don't even want to come to one of my clinics because it's near a low barrier shelter, and he's just afraid of that area. And there's a few shelters in DC that where there's a lot of violence going on, like clients assaulting clients. I've seen security guards like manhandle um clients. I've seen security guards definitely not approaching any sort of conflict with any sense of like training about trauma-informed care. I'd worry about safety too, honestly. So some of these, yeah, they're dirty too. There's a lot of bed bugs, a lot of lice. So I think, there are other ways you could do it. You could create a safe space to use, heroin or drugs, right? I think New York, was it New York that's opened up the first one of the first ones? DC has opened up a sobering center. I don't think you can actually use in there, but you can go there high. So low barrier shelters will always serve um, uh, will always have a service as far as you're allowed to come in if you're drunk or high, but asking them to accept, people to use on premises, there's just so much kind of bureaucratic stuff and a lot of safety concerns that it would be quite a challenging feat. And one thing when you mentioned that, you mentioned some of the encampments and trying to get people into shelters, and we have to be honest that there is a segment of my patients who are very difficult to house. They may not just want to be housed. It's a very, no, please don't take this the wrong way. It's a very small portion. By far the majority of folks do want to be housed, but there is a proportion who either don't want to be housed based on their personal choice, which we need to respect, or I say that they're difficult to house because they have a severe mental health illness that prevents them from living independently. And there are some solutions to that, but we're not doing enough to help those individuals. By the way, the solution is something called permanent supportive housing, if done correctly.
Thank you, Dr. Jafari and Katiana, for your question. I see Emily, you have your hand up.
Yeah, thank you. And thank you so much for speaking with us. This has been really interesting. I think, especially seeing it in context of DC, where we're like so close to, and some of us are living in directly. So kind of a two-part question, but when you were talking about patients who don't engage with care, I was just kind of curious, like learning a little bit more about that, and just overall when you are approaching people, kind of what is that experience like? Do you find, I think when we were kind of talking about stigma as well, I think sometimes there's like a fear to engage, or like people just don't feel confident enough to like talk to people who are unhoused. And like, do you notice that at all, when how it might impact like their overall mental health if they don't have a lot of close relationships or don't come in contact with like a lot of people, maybe like how those things kind of work together?
Yeah. Trust is a huge issue in what we do. A lot of again, a lot of my patients have been through a lot of trauma, a lot of violence, a lot of broken promises, a lot of doctors or case managers saying that we'll do this for you, or we'll get this apartment for you. And not to blame them, but sometimes the process falls apart and then you lose that trust. So I don't know if this kind of addresses it, but you have to be very, very careful what you say and what you promise, because as with any doctor's appointment, building that therapeutic relationship, I think, starts with you respecting the person, but also fostering a sense of trust with them, because if you say you're going to do something, you better do it, because if it doesn't happen, your patient is gonna blame you. And again, and with the understanding that they've been through a lot in their lives, and they have been used and abused, and a lot of my patients are actually quite lonely, and some of them will just come and nothing will be going on, but it's pretty obvious they just want someone to talk to. Did that kind of answer your question? I'm sorry, I know it's a
Yeah.
little vague.
No, that was helpful. I think just like when we talk like, I think in our program, a lot of what we talk about is like factors outside of health that impact health. So thinking about like a mental illness, I'm sure that's only, if someone has that underlying going on, it's probably only compounded by not having a lot of people to talk to, or like living with the stigma of being unhoused or things like that. So I think that makes a lot of sense, what you said.
Yeah.
Thanks.
Maggie, do you want to ask your question next?
Yeah, so I was just wondering, in what are some ways you think would be beneficial in kind of increasing the focus of homeless medicine in other cities that might be more kind of apprehensive about that approach? And if you could just talk a little more about like what these apprehensions or barriers are in cities outside of DC.
Oh gosh. Well, first of all, I love sharing my opinion, but I'm not qualified for outside of DC. I'll say a few things. Again, just for my patients, but my patients are generally more often be chronically homeless, more often to be Black, male, and more often to have a fairly significant chronic mental illness. The most challenging part of my job is having someone who's psychotic come in, and not having a great plan to address their mental health, because if the severity of their mental health is to a point where they have zero insight, I'm often talking about my patients with paranoid schizophrenia or schizoaffective, or simply someone who without insight into their mental health. It's very challenging to try to find ways to give them wraparound services, In DC, we do have a lot of resources in DC. We have community behavioral health organizations called core service agencies that are approved by the Department of Behavioral Health. And that's their job. They have these ACT teams, assertive community teams, that their job is essentially to take on these difficult patients who don't want to engage in healthcare, so that they can go and find the person out in the community and try to provide services to them while they're out there. Unfortunately, what happens is a lot of these organizations are overworked. A lot of people are, underqualified or new to the position. And three, a lot of them will say, oh, the patient doesn't want to engage, we're going to take them off our roles. And I'm like, no, the whole point of this person being on an ACT team is the fact that they don't want to engage. Like I thought that was the whole point of this person getting intensive, behavioral health, psychiatric, and case management services, because they don't want to engage in the service. And then the other part is every city is completely different, and you cannot think that one model will work in another city. And so you have to keep that in mind. Yeah. And you have to think of the scale of the issue, of course. I mean, and your population. Remember, like I said, if you want to start some kind of program to provide medical care for the homeless population, you really need to know your homeless population, right? And you have to be kind of direct in what you're trying to do. I'm trying to provide medical services to individuals experiencing homelessness who are chronically homeless, who may or may not have a mental health or substance use disorder, So, if you got to think about your population when you start thinking about these programs. Yeah. And tailor it to specific, unique things about your location. I've noticed patients, for some reason, I feel like DC and Baltimore are completely different, and it's only an hour away. And it's bizarre to me how different, they might approach something compared to how we approach it. Anyway.
Thank you.
Good question. Thank you.
Do we have any more questions from HAPI students? We have just under 15 minutes left.
Yes.
Anya.
Yes, thank you for coming in and talking to us today. So I have kind of a more personal question, which is, do you find your work to be sort of like emotionally sustainable? And do you ever feel any sort of burnout? Have there been any moments where you felt particularly like, I'm sure you've seen some pretty tough things, so any moments where you felt particularly defeated? And also, what do you see as wins, and when do you feel especially fulfilled?
Great question. Yes, absolutely. I feel burned out. And not just for me in the homeless outreach team that I'm a part of, but among my organization, provider wide. In fact, this isn't this is public now. The providers are trying to unionize because they're so unhappy with the way things are going at Unity, and we'll be voting on that probably next month. I've always said, and I recognize burnout in myself, and I usually recognize it when I'm more curt with my wife and kids, when I come home from work, or oftentimes I'll talk to my colleagues and we'll be like, why are we so exhausted? Do we have COVID? And we'll test ourselves for COVID. And it turns out the fatigue is actually just from work, so you go home and you're just exhausted. So we're always talking about signs of burnout and getting ahead of it. So yes, there are tough days when I'll lose my patience and I'll say something I regret to one of my patients, and then I'll realize immediately that it was nothing that the patient said. It was just me and what I was going through, and it takes a lot of work to recognize that in yourself. And I've considered going part-time too, because I like what I do. I don't like doing it like 5 days a week, for the number of patients that I'm expected to see. Okay, so that was burnout. Oh, well, you had some, oh shoot, what were the other two related to that?
Oh, just like on the flip side, are there particular
Oh.
moments where you've like felt a big win, or just felt especially fulfilled?
Well, so I'm an internist, so we're big nerds. So honestly, some of the most basic wins is when I was working at the pandemic hotel, and I had a couple patients with uncontrolled diabetes where their A1C was way through the roof. And because of we had a clinic right there in the hotel, they could come in and see the doctor like every time we were there. Like, again, I do like concierge medicine sometimes. And we just worked on getting their diabetes under control. And on sometimes some simple wins is just seeing that A1C number go down or seeing their blood pressure go down. Those are great wins, honestly. Some other wins is finding a pregnant woman who is unsheltered or unhoused and getting them into prenatal care. That feels good sometimes, even though I'm not involved in the prenatal aspect. But I'm always involved in kind of that the first kind of introduction to prenatal care and trying to get them, hooked up into our OBGYNs and midwives. Those are nice. And then one of my patients is a great artist and he would give me artwork, and man, those were fun moments. And he was able to get housed. And then hearing your patients are in an apartment, that's always feels good. Yeah. Simple stuff like that. So little wins, not like population wide. That makes me sad, if I think of like how we're doing on a large scale. But whatever work you do, you need to identify wins as small as they are. When I'm in street outreach, there's not a lot of wins. Sometimes a win is just having a patient give me their name and date of birth. Like, they trust me enough that they give that to me, or even having them come to see me at that clinic, even though we're not doing anything specifically medically related. Just having that buyback from a patient is a win. So you need, whatever work you do, you got to identify what makes it meaningful. And if you're not finding a lot of meaning in your work, you might have to reconsider what you're considering a win. Start small. You need to find some joy in what you do. Thank you. That's a great question.
And I think we might have time for just one more question. So Jasmine, do you want to ask our last one?
Yeah, thank you so much for your presentation. It's truly interesting and fascinating. I'm more curious about the payment models. You mentioned that that Unity is an FQHC. So I'm just and you mentioned a little bit about like registering unhoused people for Medicaid and different insurances available. So I'm just curious, like, how does the payment model for this particular FQHC work?
Great question. So at Unity Healthcare, I don't have the exact numbers, but as a whole, among other health centers, the vast majority of our revenue actually comes from Medicaid and Medicare. So most of our patients are actually insured, and that keeps things afloat. So most people have Medicaid or Medicare, or they'll be in the process of signing up for like DC and Medicaid. Then a smaller portion is self-pay. We actually, as an organization, never go after anyone for bills. They might have a bill that accumulates in their medical chart, but Unity has never been actively pursuing bill collections. I think that's mostly to just report to, the federal authorities that, hey, this is how much free care we're giving. And then a very small portion of revenue comes from grants and funding like that. Like, some of the things I do comes from grants, because a lot of the folks I see out on the street, don't have any sort of insurance. So just to answer your question, yeah, most patients do have Medicaid. Some of the challenges again is, it's volume too. Let's be honest. If even though we're a nonprofit, we're still a business. So you have to, if you're like thinking of a way to make this sustainable, you got to figure out a way to get your patients insurance. If you're not getting grant funding right, you got to find a way to see more people. And my pet, the thing I always complain about is we focus so much on getting providers to see more people, right? So at Unity Healthcare on a busy day, a provider will see 12 and 12, so up to 24 individuals a day. And these are not simple like issues, right? Because a lot of our patients have complex medical needs. So my whole thing is, well, maybe instead of like pushing our providers to burn out quicker by making, telling them to see more people, maybe we should get more efficient billing. Maybe we're underbilling, and maybe there's a lot of money there that we're not getting from Medicare or Medicaid based strictly on understaffed billing department. One thing that I do to help and kind of increase access too, by the way, my patients love this, is telemedicine has been great. So if I have a number for my patient and I have an abnormal lab, I will actually call them and treat it like a telemedicine visit. And the patients love it because they're like, hey, my doctor's spending 20 minutes with me. But I'm like, well, I kind of have to do this because I'm kind of helping my organization now and bring up my numbers, but I'm glad we're both happy. Yeah. Did that answer your question?
Yeah, that was super helpful. Thank you.
But as far as like
Oh.
street outreach, a lot of those are just a lot of those aren't billable because the vast majority don't have any sorts of insurance, and there's a lot of barriers to get them to see one of our case managers or see someone to get enrolled. Yeah.
Yeah, and actually, I just thought of two other quick questions.
Oh,
What
that's fine.
is
Yeah, go
so
ahead.
is this a pilot program that that is unique to
Mhm.
Unity, or do most FQHCs have this type of outreach program to reach out
Yeah,
unhoused individuals?
great question. No, it's not a pilot. Unity Healthcare started in the mid 80s, and the name of the organization was Healthcare for the Homeless. So we actually started with that in our like organizational blood. So no, it's not a pilot. But as far as other FQHCs in the city, I I'm fairly sure Unity is one of the only ones who does it, and I think mostly because it's historical. It's kind of it's just what we were known for, and we've had a lot of good leadership that has maintained it. It it went away during COVID, but now it's coming back, so that's part of it. Um, it's just something we've done for a while. What was there was a second part of that question? I'm sorry.
Yeah, just if other FQHCs do it, but how many patients do you have? Like how many programs people do you um I guess
Mhm.
keep track
Do
of?
I
Yeah.
see?
Do you
Keep
see?
track
Yeah.
of? So I don't keep like a census. Like I don't have a list of all my patients. During a typical outreach, which could last as short as 2 hours up to 3 hours, we could see, it depends on how busy it is, but we could see upwards of 6 to 8 folks. And a lot of them are just basic, hey, how you doing? Hey, here's my card. I'm working at this clinic. Come and see me. At the day centers and the healthcare centers, um, that number can go up to 10 to 12 per like morning or afternoon session.
That's great. Thank you. I was asking because we've met with several FQHCs, and yeah, I know the hard work that FQHCs do, and knowing that there's one in DC that particularly works with unhoused individuals is really great. So thank you.
Yeah, yeah, you're welcome. And by the way, there are other FQHCs have patients who are unhoused, okay? Bread for the City, Mary Center, Community of Hope, Women Walker Clinic. We're by far not the only one. We just happen to be the largest and with a lot of history in what we do. Okay. Yeah.
All right. So I know we're at time. So I just want to end by saying thank you, Dr. Jafari, for coming to talk to us and being so open about your experiences. I know that I think that people discount the complexities of being unhoused, and then adding that on to the complexities of healthcare is really difficult to explain, and then I'm sure also experience and treat. So really appreciate you coming to talk to us and lift this topic up. And so just how important it is to give proper care and treatment to unhoused people.
Yeah. Thank you. Thanks so much for having me. Thanks, Dr. Myers, for the invitation. Yeah, if you want to share my email, that's fine. If there's any follow-up questions, don't feel free to email me. I'm happy to respond. Okay.
Great.
Great,
I
thank
will share that email with